5. Time. 15.
Okay, thank you. I think when she said human, she meant deeply flawed, which is absolutely correct. So basically, in 1985, Oliver Sacks wrote a book about a man who mistook his wife for a hat. So the man in question was a brilliant musician who developed a very strange visual disturbance. At the end of a consultation that he had with Oliver Sacks, he stood up, gripped his own wife's head, tried to pick it up, because he had quite literally mistaken it for his hat. Now, Oliver Sacks was a very inquisitive and careful physician. Through a detailed assessment, he was able to establish that this man's visual pathways were absolutely intact, that he could see perfectly, but the problem was he didn't recognize what he was seeing, and in particular, he didn't recognize faces and people. Now, Oliver Sacks was able to surmise there must be a bit of brain that's important for facial recognition, and this man must have a lesion of that bit of brain. But he had absolutely no way of establishing which bit of brain that was. He had no technology in order to move things any further forward than that. Now, I started studying medicine in 1985, and it was still a very clinical time for neurology. So neurologists made a diagnosis by correlating patient stories, their examination, with what their knowledge of neuroanatomy at the time. And we relied very heavily on anatomists and on brilliant physicians in order to teach us what clinical signs meant in terms of a diagnosis. Now, I want to talk about a patient that I have personally looked after many years after that initiation into medicine in 1985. And her name is Eleanor, and I want to describe her journey through a sort of evolving health service. So Eleanor was born in 1985. She fell ill in the 1990s when she was 12 years old, and I met her for the first time when she was 20. Her problem began as intermittent difficulty with clumsiness, with stumbling, and with falling over. In general, Eleanor was actually quite well. She was actually a graceful ballet dancer when she was at her best. But for a week at a time, just every now and again, she would start tripping over things, she would start dropping things. It would last about a week. Sometimes it was so bad that she had to take to her bed, and then she would spontaneously recover. Now, she saw several doctors over the course of her life, over the course of the years, and they examined her, they did investigations, they couldn't find anything amiss. She sort of resolved herself to the likelihood that she'd never know what was wrong with her, but she came to my door after a dramatic deterioration. So when Eleanor left school, she got a job on a cruise ship. And this was sort of an amazing sort of opportunity for her that actually turned into a disaster. Because essentially, as soon as the ship set sail, Eleanor found she was unable to walk. So she was just bouncing off the walls of the narrow corridors, she was stumbling, she was falling. The sea was reasonably rough, but she didn't feel sick. She just couldn't walk a straight line. The longer the trip went on, the worse Eleanor was getting until she was again occasionally having to take to her bed. She eventually disembarked from the boat in St. Lucia, good for her. And basically, as soon as she landed on dry land, she was miraculously able to walk again. Now, that's a story that Eleanor told me in clinic, and I'll be brutally honest, if you want to know the inner lives of doctors, I was essentially thinking, oh shit, what the hell is this, when I heard this story. This did not strike a single chord of recognition in me. I examined her. I didn't find any explanation for this difficulty walking, and I really didn't have anything very enlightening to say to her at the end of that first consultation. But I relied on the neurological process. I relied on the principle of how we diagnose in neurology, which is to try and locate the disease somewhere in the anatomy before we worry about what the disease is. I'm always pressing the wrong one. So basically, what I needed to do was first of all say where in this map of the nervous system the problem is, and then afterwards worry about what it is. So if I think in terms of things that cause a person to lose balance, the nerves in the feet are incredibly important to balance because they allow you know where your feet are in space, they allow you feel the ground underneath you. But I'd examined Eleanor's sensation in her feet, it was fine, it was unlikely to be the problem. The muscles around the hips, around the back are important for keeping us upright and for allowing us to walk in a straight line. If they were weak, they could cause a problem. In Eleanor, they were strong. Our ears, I'm not pointing that very well, I promise I'm not doing. So basically, your ears are important to our balance, but if you have an inner ear problem affecting your balance, you feel sick, you have vertigo, you have dizziness, you have tinnitus. She didn't have any of those things. I didn't feel they were the locations for her problem. It was likely that the problem existed in her brain. At the back of our head, we have the cerebellum, which controls coordination and balance. And our brains obviously have multiple complex motor areas important for controlling posture and complex motor activity. So I decided that the place I needed to look for Eleanor's disease was in her brain. First thing I did, obviously, is an MRI scan of her brain. So that's been available since the 1990s. It allows us to look at the brain in great detail. It was normal in Eleanor. Now, the MRI scan is far from infallible. So an MRI scan is essentially a photograph. It tells you nothing more about how a brain is, it tells you no more about how a brain is functioning than taking a photograph of a computer circuitry would tell you how your computer is running. It tells you nothing about the microscopic of what's going on microscopically in the brain or chemically or electrically. So next thing I did was I started to look at the brain function in indirect ways. So I did an EEG, an electroencephalograph, which measures your brain waves, the electrical activity. That was normal. I did a PET scan. That looks at the way your brain uses glucose. So if a bit of your brain isn't using as much glucose as the rest, that might imply a problem in that bit of brain, and that might imply that that's the source of the problem. In Eleanor, it was once again normal. Now, the obvious flaw in everything that I was doing was that I was doing it when Eleanor was well, and that had been the problem with all the previous doctors also, is these bouts of unsteadiness were gone by the time she came to the clinic. Obviously, what I needed to do was see her when she was unwell. Clearly, what I wanted to do was take a cruise to St. Lucia with her, but obviously the NHS were not willing to stretch to that. So we agreed that she would ring me the next time she got one of these bad attacks, and I would admit her urgently to hospital, which is what I did. Once I admitted her, I put her in a room where she was videoed continuously, so I could see everything that happened to her. She had painless metal discs placed on her scalp so that I could read her brain waves, look at her heart rate, and then I just waited to see what was going to happen. Over the course of the next few days, she fell multiple times, she dropped things multiple times. I looked at the video. Every time that Eleanor dropped something or every time she fell, every muscle in her body just went completely limp like a rag doll. She dropped, her muscles re-engaged, and she was fine again. Her heart rate was fine, her blood pressure was fine, but when I looked at her brain waves, there were big bursts of electrical activity that should not have been there every time she fell. That presented the diagnosis, so Eleanor suffered with epilepsy. So epilepsy is a disease where you get these unwanted electrical discharges in the brain. Now, everyone's aware of convulsions. If you have a convulsion, that means that the whole brain is involved in the electrical discharge simultaneously. But if only one little bit of brain misfires, the symptom of the seizure will represent what that bit of brain does when it's healthy. So there's a bit of our brain that is controlling the postural muscles that's keeping me standing upright, that's keeping you sitting upright, and that's unconscious. In Eleanor, that bit of brain had this unwanted electricity surging through it. When the discharge was there, the muscles lost tone and she collapsed. And when the discharge disappeared, the muscles re-engaged and she was fine again. That was the first mystery solved. The second mystery was, okay, but why couldn't she walk on the cruise ship? So medicine is a clinical specialty, so what you do is you listen and you pay attention. I went back to the videos and I watched again, and a pattern began to emerge. I saw Eleanor sitting cross-legged on the bed, somebody knocked on the door, she turned to greet that person and she had a seizure. Her telephone rang, she reached to pick up her telephone and she had a seizure. She picked up her cup of tea, she had a seizure and dropped it. Eleanor's seizures were being triggered by the initiation of movement. So Eleanor had a thing called reflex epilepsy. Now, perhaps you think you don't know what reflex epilepsy is, but you probably do. Most people are aware that flashing lights can trigger a seizure. That's reflex epilepsy. It's seizures that have a specific trigger. but there are triggers that are much rarer and more unusual than flashing lights. There is a thing called eating epilepsy, which is where you have a seizure when you eat. Thinking epilepsy, seizures triggered by thinking a certain thought or a certain word. There's reading epilepsy, there's musicogenic epilepsy. I have one patient who has seizures whenever he hears classical guitar music, fortunately easy to avoid. In Eleanor's case, she was having seizures triggered by movement, and I could only assume that something about the movement of the ship that she had been on was engaging her postural muscles in such a way as it was triggering her to have recurrent seizures and stopping her from walking. So now I had my diagnosis, I could treat her. So I put her on epilepsy drugs. I hoped that that would be the conclusion to her story. Unfortunately, it wasn't. So 30% of people who have epilepsy don't respond to epilepsy medication and the seizures continue. And that was the group into which Eleanor fell. What was worse was that things got gradually worse. She used to have kind of 1 week stretches of seizures, but they got longer and they got closer together. She started having periods when she had to stay in bed for her own safety. Once she fell through a glass door, and because she's wide awake, she could feel herself crashing through the glass. She could feel herself landing on the shards. So obviously things were getting quite desperate, and I've really felt my back against the drawing board. And all I really could do at that point was go back to the beginning and try again with the same investigations. Now 3 years had passed, and this time around her MRI scan was abnormal. This time around she had a developmental abnormality in the right frontal lobe, so at the front of her head. Now that hadn't just grown, that hadn't just appeared. Much like our iPhone screens, MRI resolution was improving. Technology had finally found the ability to spot something that had always been there. It was a scar there since she was born. The technology had finally caught up with it. Knowing that lesion was there gave me the opportunity to consider alternative ways to help Eleanor. So if you remove the lesion, you potentially are removing the electrically unstable bit of brain. And if you do that, you potentially could cure her epilepsy. Now, I've made that sound very easy, but apparently brain surgery is not very easy. So obviously there was going to be more to it than that. So this lesion was sitting in an area called the supplementary motor area, which is a region very important for controlling postural muscles. So it fit beautifully with the theory of her seizures. But that bit of brain wasn't just producing seizures, it was also controlling normal movement. So what did Eleanor stand to lose if I asked the surgeon to take that bit of brain away? And perhaps she could end up paralyzed in a wheelchair. And was that a risk worth taking? Obviously, more needed to be done to try and investigate the risk for Eleanor. I needed to know if you take away a bit of unhealthy tissue, you're going to take away a bit of normal brain with it. You need to know the function of that normal brain before you remove it. And that's what I had to establish in Eleanor's case. So functional MRI is, as the name suggests, a way of locating functions in the brain. So what you do is you ask someone to lie in a scanner and you give them something to do. So in Eleanor's case, tap your hand, move your arm, move your leg, move your foot. And then what you look for is changes in blood flow in the brain that indicate which bit of brain is being activated during that activity. And that tells you which bit of brain is important to that activity. So if you go back to the man who mistook his wife for a hat, if you put someone in a scanner and you ask them to look at pictures of famous people and to identify those, I was supposed to warn you before the bloody slide, but you might have already seen it now. So basically, this, if you put someone in a scanner and ask them to identify faces, this is what you see. This is what kind of fMRI you see. This is the fusiform gyrus, which is the face recognition area that certainly could have been diseased in the man who mistook his wife for a hat, but the technology wasn't available to fine-tune neurology in this way at that time. In Eleanor's case, when we did this sort of functional MRI, we discovered that the lesion was perilously close to the bit of her brain that controls her left leg. So that essentially means that if she had the operation, she could end up with a paralyzed left leg and in a wheelchair, unable to walk. On the other hand, if she didn't have the operation, she could continue having seizures and be bedbound as she currently was. So she really was in a difficult position. we needed to go further in order to try and hone this even further. So basically, when I had previously found where in her brain the electrical discharge was coming from in her brain, I had placed electrodes on her scalp, which obviously means there was bone, there were muscles, so, there was skin in between the electrodes and her brain. So it's a bit like staring at the moon sort of on a cloudy night through a telescope. What you want to do is you want to see a close-up unobstructed view. I think you know what's coming, which is basically what we needed to do was arrange to have these electrodes put directly on the surface of the brain. Close your eyes now if you don't like blood, basically. So this is what we did next, an intracranial EEG. So it's exactly the same as the EEG we'd already done, but the electrodes are placed directly over where the lesion is, and all of the electrodes are numbered. We wait for a seizure, and we see which one of these electrodes picks up the seizure first. And then we have a much more precise location about where the seizure is arising and where that seizure is arising in relation to all the important structures and the functions that Eleanor didn't want to lose. Now, I'll come off that slide just in case you get a bit obsessed by it. So basically, unless you're enjoying looking at it. Surgery for epilepsy has been around for over 100 years. And for the vast majority of that 100 years, surgeons essentially had to operate blindly based on sort of educated guesswork. So to give you an example, in 1953, a surgeon removed both temporal lobes of a man who's now referred to as patient HM. This man had epilepsy, and when the temporal lobes were removed, it did quite a good job of controlling his seizures. But unfortunately, it caused him to be unable to lay down new memories. You need at least one temporal lobe in order to form new long-term memories. So patient HM never formed a new memory after 1953. Now, obviously, when we began to get brain imaging, all of this surgery became much easier. This is an example of one of the earlier CT scans from the 1970s. This is a more recent CT scan and an MRI scan with all the incredible brain detail that it offers. So until very recently, a surgeon would operate with one of these scans hanging on the wall beside them in order to orientate them in the brain. This is what our surgeon will see if Eleanor chooses to go ahead with the operation. So what we do now is we can take all this sophisticated information we're able to gather, and we can put it on a 3D representation of the brain. So this is not Eleanor's scan, but it's just Eleanor's brain, but it's just to help explain it to you. So the red area here is this patient's abnormal brain lesion. The green area is the motor control area for the hand as determined by functional MRI. The blue area is the motor tracks, so to get the motor information down to the limbs. And the orange are the language areas. So working with the 3D representation of the brain like this, it allows the surgeon to navigate more precisely to remove the lesion and avoid important structures. They will also have the addition of computer navigation in order to help them in that, to produce the safest possible operation. Now, once we had this sort of 3D representation for Eleanor, we were able to establish that we couldn't remove the entire lesion because it was overlapping some of the motor control area for the left leg, but we could remove part of the lesion and that could still cure her epilepsy. Now, when we come to these sort of decisions, we offer people benefit risk statistics based on experience and based on this data. So the statistics that Eleanor was offered was she had a 1% chance of something catastrophic happening during the operation, resulting in death or serious disability. She had a 10% chance that the operation would cause her to be paralyzed in her left leg. The chance of curing her epilepsy, 30%. So she had a 70% chance that she would go through all of this and it would make no difference to her whatsoever. But you've got to remember that Eleanor is at this point almost bedbound because every time she tries to get out of bed, she falls. So these are odds that some people will consider. This is not life-saving surgery. Eleanor could live with her epilepsy, so this is very much a choice. When I put that choice to Eleanor, she declined. So this is not a happy ending Hollywood story. This is a real story. And basically, from Eleanor's point of view, the MRI scan wasn't even in use when she was born. Functional MRI is a 21st century invention, and this sort of navigational surgery is a brand spanking new invention. So she feels that it's worth hanging around for a little bit longer to see what else new will become available, something that presumably is just a twinkle in the imagination of someone at the moment, and I think that is realistic for her to believe something new will become available. So the bottom line is there's been huge advances in the way we practice neurology over the course of the last 20 years. Those advances are technological, there are advances in genetics, and also in the kind of medicines that we use. But there are other areas in which we have advanced very little. We can't repair brain damage. We can't return function once it has been lost. And the truth is that for Eleanor, the things that really benefited her at the end of the day were just old-fashioned medicine. So basically, she benefited from advice about how not to injure herself, from physiotherapy, from getting help with her disability payments. And more than anything, she benefited just from, the gentle arts of caring, of listening, of acknowledging her suffering, and of just trying to help her. Thank you.